What I'd been asked to speak about is the role of ex vivo lung perfusion in transplantation, and I know many of you are not involved in transplant, but I think we'd like to show you where the field is going. I would like to disclose that I am a founding partner and chief scientific officer of 3 companies that have rolled out of the work we're doing: Perfusics Canada, Perfusics USA, which is now Lung Bioengineering, owned by United Therapeutics, and XOR Labs Toronto. And we've received significant research support from ex vivo perfusion and ongoing support from United Therapeutics for research as well as clinical trials. But I do need to cover the work that's exactly related to that. First of all, what is EVLP? Why would you want ex vivo lung perfusion? What the current role is in lung transplantation, and some of the future possibilities. So basically what many over the last 50 to 100 years have dreamed about the idea of keeping an organ alive outside the body to support it, and that really hasn't been achieved in a meaningful way. And what we did when Marcelo Cipal was working with me as a fellow in the lab was develop a system where we could support a lung in a chamber, ventilated by an ICU ventilator, perfused by a centrifugal pump, and actually with the membrane swept with the hypoxic hypercarbic mixture, so that you can create an opportunity to assess the lung's ability to add oxygen to the perfusate and remove carbon dioxide, and really putting together everything we've learned over the years in protective lung ventilation and perfusion to create a system that you see here that can support a lung outside the body for over 12 hours at normal body temperature. But really, like, ex vivo lung perfusion is not the end. Just pumping an organ, as people sometimes refer to it, is not really what the power of what we can achieve with this. But really, it's can we aspire to not just preserving organs in the status that we found them, but actually creating organs that are better than the way we found them? Can we create an organ that is up to the task of transplantation? Can we create an organ that will look like self, so it will not be rejected? Can we create an organ that will outlive the recipient that we put them in? So I think for those of you that haven't seen this, this is what it looks like with human lungs at 37 degrees. Breathing in the Toronto ex vivo lung perfusion system. You can bronchoscope the lungs and sample, and I'll show you some of the treatments that we're doing. This particular video shows the delivery of adenoviral vector for IL-10 gene therapy to immunomodulate the lungs, and this is work that we're currently bringing to clinical trial after almost 20 years of development in the research laboratory in Toronto. So we published the first clinical trial of normothermic ex vivo lung perfusion in the New England Journal in 2011. And basically what we showed that when we took donor lungs that we would not normally transplant and subjected them to ex vivo lung perfusion assessment and treatment, we had equivalent results to standard donor lungs that we transplant in our programs in a contemporary time period. And we've now done 290 such transplants of ex vivo lungs at Toronto General Hospital. What's very interesting, and Alec alluded to the fact that we've really not made major inroads into chronic lung allograft dysfunction, we're seeing this trend that lungs that have been treated with ex vivo lung perfusion have a greater freedom from lung allograft dysfunction in the long term. And this is early days yet, but it really does speak to the fact that the early inflammatory injury of ischemia reperfusion injury does impact and probably fuel the alloimmune response and further healing in related injury or regenerative injury in the lung. So as in many organ procurement regions, the number of donors in our region has been very flat, maybe a slight increase over the last few years, but we've been able to double, triple, and quadruple the number of lung transplants done per year in our center by looking at ways to protect lungs better and be able to evaluate them and use them. And you can see that the current profile in our program is that about 30 to 40% of the lungs we transplant now are ex vivo perfused lungs. And this has also helped us to really move from late adopters to donation after cardiac death donors, which are a bit more uncertain donors to use as a lung transplant surgeon, to being leaders in the world in the percentage of donation after cardiac death lungs that are used. And again, this is something that is an untapped source of donor organs, largely untapped in the United States right now. And what we've done is actually build an organ repair center. There's our lung system. Our liver team is in Toronto has worked on a similar system that you see there, and others are working on the heart and the kidney. And OR 18 at Toronto General Hospital is our organ repair laboratory, where we look and treat lungs on the system. As you've seen it here, this is in the operating room, and it's basically a mini operating room, and we're building a couple more rooms now as ex vivo liver and kidney are coming on for clinical use. So what are some of the treatment strategies? We've been studying various different strategies. I alluded to the gene therapy, which was my sort of original dream and idea that we could modify the lungs, but we've been looking at perfusion, drugs, biologics, inhaled gases. Marcelo's working on the immunocloaking concept, and we're also doing some work on cell therapy. But the majority of lungs that we turn down as a donor are usually lungs that have an X-ray that looks like this. They're probably a little wet. PO2 is only 230. Put them on EVLP, you can see they're sort of fairly dense and edematous looking. After 3 hours, the edema clears and the parameters improve. We transplant the lung, and the patient arrives in the ICU with a PO2 of 420 and is extubated the next day. So these are lungs, it just gives you the confidence to use these lungs. We're looking at the treatment of lungs. The second most common reason to turn down a lung in a donor OR is concern about a pneumonia with an infiltrate or pus in the airway. And what we're doing is putting these lungs on the ex vivo circuit, treating with high-dose antibiotics, and showing that we can bring these lungs to sterilization. We're actually looking at a strategy to actually lavage out the endotoxin as well as treat with antibiotics, and define when these potentially infected lungs are actually safely transplantable. Marcelo Sipel has had a very innovative idea to actually start to look at, can we sterilize Hep C infected lungs and make them safely transplantable, and has been looking at decreasing the viral load as well as treating with the new antiviral agents in lung transplantation. There are well over 400 donors every year that have excellent lungs just in the Northeast here, that the lungs aren't used at all because of this. So the clinical trial we have right now is that the preclinical trial is Hep C infected lungs are sent to us. We divide them up and put one lung on a circuit and a second lung on another circuit, and look at various treatment strategies to sterilize these lungs. And Marcelo's been looking at completely washing out and diluting out the virus, looking at energy sources like UVC and so on to look at sterilizing the lungs. In fact, we've actually transplanted the first patient where we used Hep C positive lungs, treated them ex vivo, transplanted him, and treated him with anti-Hep C antiviral drugs, and he's now about a year out free of hepatitis C. You often find pulmonary emboli in donor lungs, and small ones we just fish out, but this patient had an element of pulmonary hypertension, the donor, and you can see some relatively old-looking clots as well as new clots, and we didn't know if that lung might have some fixed pulmonary hypertension. So we brought the lung back, put it on the EVLP circuit, treated it with alteplase as you would with your patient with a pulmonary embolism, watched the pulmonary vascular resistance and pulmonary artery pressure come down, We did a biopsy. The pathologist saw that there's no signs of medial hypertrophy, and it was a safe lung to transplant, and so we successfully transplanted that lung. I've been looking at the immunomodulation. This is really where I think this is going in the future. IL-10 is a particularly important regulatory cytokine in transplantation in that it regulates the innate immune response at the time of ischemia, reperfusion, injury, and downregulates neutrophils and macrophages. But it also is a particularly important regulatory cytokine in the adaptive immune system, moving towards a more regulatory or tolerant type T cells. So we use the common cold virus, the adenoviral vector, take the virus genes out and put our IL-10 gene into it, which the vector is very good at carrying the gene into lung cells and producing IL-10 locally. So Marcelo did this with human lungs and showed that by treating these lungs ex vivo on the circuit, you can improve the oxygenation, improve the pulmonary vascular resistance, and bring these non-transplantable lungs to transplantable quality. We also showed that this treatment significantly downregulates the inflammatory cytokine profile that's seen in the brain-dead donor organs, and IL-8, IL-1 beta, TNF-alpha, and so on are downregulated by this transduced transgene. So certainly showing that we can genetically modify the donor lung to function better after transplantation. United Therapeutics is funding a first-in-man phase 1 trial of IL-10 gene therapy in lung transplantation, and we hope to get that initiated in the next year. We've been looking at the concept of can we use mesenchymal stem cells to repair the donor lungs outside the body. I mean, certainly a very severely damaged lung could be stripped of all of its cells and then use your own bone marrow stem cells to build a lung that is you, and that is obviously a further down the pipe, and there are a number of people, Tom Waddell, Harold Ott, and others working on that. But really, mesenchymal stem cells do have the ability to respond to injury stimuli, and certainly a transplanted lung is certainly stimulus extravaganza, where you can see that a number of the things that stem cells can do can turn down some of these processes that are all turned on at the time of a lung transplant. So we've been looking at how to deliver the cells to the lung. Pierre Mordaunt, a fellow from Paris, and Daisuke Nakajima from Japan have been working with us, and you can see the green cells here showing that these stem cells are trapped in the lung and in the interstitium of the lung, and we've also shown that it can downregulate the IL-8 and the IL-1RA stimulus in the ex vivo lung. So again, once you diagnose a problem with the lung, you can work on it and say what is the specific problem and treat it in a targeted fashion on the ex vivo system. So how do we put this all together? We envision that the future state will not just be all of us flying out in the middle of the night in 5 different Lear jets to go pick up an organ and go back to our own center, but really that organs would be sent to an organ repair center, repaired, and optimized, and then distributed to different centers to the right patient at the right time. We have built the first organ repair center in the world. This is in Silver Spring, Maryland. This is Lung Bioengineering. It's a 3-story building. It has 6 rooms for repairing lungs. We've trained these people that are organ perfusion specialists. They're all trained at Toronto General Hospital to perform ex vivo perfusion assessment and treatment of organs. We have a control center, and these organ perfusion specialists send the data to us. I can see it on my iPhone. Tom, Marcelo, and I, we get pulmonary vascular resistance, gases. We can look into the lung with the bronchoscope. We can watch the ventilation, deflation, compliance, and everything, and then sign out a lung as having met the parameters for a transplantable lung. And so we're currently doing this as a trial in the United States. The Mayo Clinic at Jacksonville, the University of Maryland, Cleveland Clinic, and Duke University are currently in this trial to look at the feasibility of sending lungs to a repair center. we're building in partnership with the Mayo a second lung repair center in Jacksonville and a third one in Phoenix, Arizona. So you can see that transplantation is really changing, and ex vivo lung perfusion has really opened the door to a platform of things you may never have imagined possible, that we don't just cold preserve a lung anymore, but it's really assess it better with bioprofiling, which I haven't really touched on, look at functional assessment, and really look at organs that could be improved. And I think the future will show that all organs could be improved, all organs can be modified to be better prepared for the task of being transplanted into a host that's going to try and reject them forevermore. And I think that will lead to more transplants with better outcomes in the long term. So I've certainly shown you some of where we're going in this area, but currently, what are the current indications and current clinical applications of ex vivo lung perfusion? Certainly lungs that have a low PO2, lower than the threshold of or 300 millimeters, or declining, a concerning declining trajectory in the donor. Bronchoscopic findings concerning for aspiration. If you see food particles or some evidence of aspiration in the lungs or in the contralateral lung to a lung that you want to use, you really need to be able to assess how bad a problem you have, and that's another very common indication for us. Lungs with significant pulmonary edema, it's very easy to dry out lungs with neurogenic pulmonary edema. Significant infiltrates on a donor chest x-ray, and as I mentioned, donation after cardiac death donors. Donors with a pulmonary embolism, I showed you an example of that. Sometimes logistics, multiple donors at the same time where our ORs are not able to accommodate all the transplants. Earlier this year, we did 5 double lung transplants in 28 hours. At the same time, did 2 lung transplants and 3 liver transplants in our hospital. And the way we did that is we put 2 lungs on EVLP and just parked them until we got lung transplant surgeons and ORs available to keep going. So I think this shows you how it can scale up a program. Some donors with a high-risk donor history, again, has been particularly ones where you have a trauma victim that has reasonable blood gases and maybe little infiltrates, but they've had 30 or 40 units of blood transfusion. I think that's a high-risk type of lung that you can improve. I've talked to you about the clinical trials, the gene therapy, and the Hep C donor. We like to be pretty liberal about receiving lungs that are retrieved by other programs, and there are many surgeons that we know they'll retrieve a lung and it'll be fine. Sometimes we end up opening the cooler and finding a really nasty surprise, and so for those times we just put the lung on EVLP and see that it is okay, and that standard type of preservation and expectation of lung function is there for us. Thank you very much.